Hello, everyone. Thank you for joining me today to hear about some new and exciting technologies in the field of chronic pain management. I'm Dr. Russo. We're going to get started. A couple words about myself. I'm a pain management doctor and physical medicine rehabilitation specialist. We have 3 offices, one in Hood River, one in the Dalles, and one in the Portland area. I've been practicing interventional pain management for about 15 years. Did my medical school training at the University of North Texas, residency at Mayo Clinic in Rochester, Minnesota, followed by a pain management fellowship at OHSU in Portland. Been using neuromodulation and regenerative medicine as treatment modalities for chronic pain throughout my entire training and practice. So it's a evolving area of technologies that I've been familiar with and have enjoyed seeing make a huge impact in patients' lives. A little bit about our group. We are a comprehensive and interventional pain management team. And what that means is that we approach the treatment of pain individually and holistically. So we recognize that pain is a body, mind, and even spiritual concern for patients. And so we want to come at the diagnosis, treatment, and management of pain using as many modalities as possible. So in our group, there's myself, Dr. Riggert, Dr. Kimlani, and Dr. Smith. Neuromodulation and other modalities for the treatment of pain. We work alongside a team of other healthcare providers, including physician assistants, behavioral health practitioners, and our nurse navigators to ensure that patients' issues are really comprehensively evaluated and addressed. So like most things in the world, healthcare is becoming a team sport, and we're very fortunate at Columbia Pain Management to have an excellent team of providers available to support our patients as they explore and access these technologies for their pain conditions. Just a little overview of the conversation we're going to have today. I want to start a little bit with defining the problem of pain, talk a little bit about the different kinds of pain, give you a little bit of a historical perspective about how the treatment of pain has evolved over the last 15 to 20 years in our country and how that intersects with things like the opioid crisis. Again, review the importance of a collaborative approach in managing painful conditions, and finally leave you with some ideas about new treatment options and innovations. And then, of course, at the end of the talk, we'll have that time for questions and answers. Pain is a vexing problem. It is literally part of the human condition. And it's important to understand that you're registering for this kind of talk and seeking treatment for your pain is not a solitary experience. So in fact, we see that pain is a very common problem in our healthcare system. Over 50 million patients struggle on a daily basis with pain. Because of its overlapping physical, psychological, and even emotional dimensions, it's an expensive and complicated problem to treat. About 1 in 10 adults across the world are estimated to live with a chronic pain condition. It can be caused from other diseases and other injuries, or it can emerge de novo or out of itself. And it often strikes people in the prime of their lives. So pain is a vexing problem. It's important to understand that at its core, pain is adaptive. So the reason why we experience pain is because our bodies have built-in protective mechanisms. So pain is a protective experience that is designed to protect us from tissue damage. However, because it's so core to our biological mechanisms and experiences, it's a system that can go awry. And when that system goes awry, pain goes from being a protective mechanism to a disease in and of itself. So an injury or a disease that originally triggered a painful condition can go on past the expected acute phase and become a chronic condition. And that is when pain goes from being just a simple everyday experience that's protective and adaptive to being a dysfunctional disease that limits patients' participations in roles and activities and things that they love and enjoy. Not all pain is the same. I'm certain all of us have had some experience with this. When we talk about pain, we talk about pain that is mechanical pain or nociceptive pain. This is that adaptive protective pain that's been evolved to protect us from getting hurt. It is often seen in the context of arthritis or musculoskeletal or orthopedic conditions. It may manifest as an ache or a sharp stabbing sensation or a spasm. Again, the reason why we experience spasms is because the body is subconsciously trying to protect an injured part of the body. This is pain that is more often than not intermittent, and it has a very predictable course of onset and resolution. Mechanical pain is intermittent pain. Pain can also arise from the nervous system itself. And pain that arises from the nervous system itself is much different than mechanical pain, because the system that is responsible for helping us sense pain itself becomes the target of the disease. And we call this neuropathic pain. So neuropathic pain, or pain evolving from a disordered or dysfunctional nervous system, is often chronic. It's often a combination of sensations. And what I mean by that is patients may report feeling or feeling numbness or painful numbness. And this is pain that tends to be constant, lasts more than 24, it lasts all day long. And it may fluctuate with activity, but is usually present throughout the duration of activity. So neuropathic pain is constant pain. So I'd like you to think for a minute about the kinds of pain you experience. Is it intermittent? Is it dull? Sharp? Is it constant? Are there things you can do to ameliorate your pain? Are there positions that make it better or worse? Understanding these characteristics of your pain is often very helpful for having a conversation with your doctor about what kind of pain problem you might have and what the treatment options could be available to help with it. When did this pain start? Has it been going on for longer than 6 months? If so, that is the case definition of chronic pain. Actually, some people consider the chronification of pain to begin at 3 months. So pain that persists beyond the expected phase of tissue healing, usually more than 3 months and certainly up into 6 months, is generally considered chronic pain. How do you modulate your pain? Is it worse with particular activities or an intense day? Or are there emotional or psychological or situational factors that impact your pain? Now, most people get a little intimidated by thinking about that question. But again, we recognize that pain has a physical dimension, an emotional dimension, and a psychological dimension. The brain and the mind and the body are all connected. So thinking about what your triggers for pain might be or how you modulate pain is, again, another important point to consider when you sit down and have a discussion with a physician or provider about treatment modalities for pain. Some common diagnoses or pain conditions that you may have heard of include things like post-laminectomy pain syndrome or failed back surgery syndrome. I want to talk a little bit about this. Not everyone who has back surgery goes on to develop a painful condition after their surgery, but some do. And it's important that we recognize that there is a defined percent of people who, despite the skill of the surgeon, despite the best of intentions for having a surgery, will go on to develop persistent pain after a spine surgery. It's not that the patient has failed the treatment, it's that the treatment has failed the patient. Sometimes we talk about painful conditions like sciatica or radiculopathy. These are pinched nerves in the back or neck. Clausalgia or complex regional pain syndrome. We'll talk a little bit more about this later in the talk. These are pain conditions that arise from the nervous system itself and affects a unique group of nerves that are actually quite a good target for treatments like neuromodulation spinal cord stimulation. We often see neuropathic pain develop after nerve diseases like peripheral neuropathy or post-herpetic neuralgia, shingles pain. And finally, for patients who've experienced limb loss or amputation, they can also develop pain as a consequence of that event. Then there are pain conditions that come on after treatment for other problems. So for example, a hernia repair. Well, the inguinal nerve, it lies very close to the inguinal canal. And when a surgeon reduces a hernia and oversews the inguinal canal, there are times where the inguinal nerve can be unintentionally stretched or damaged, and that causes a pain syndrome called ilioinguinal neuralgia. After hip or knee replacements, we sometimes see painful conditions develop in the nerves around the knee or the hip. Even after simple office-based procedures like a vasectomy, we can see patients develop pain in the pelvic floor. So neuropathic pain can occur as a primary syndrome or as a secondary syndrome following treatment for other conditions. Let's talk about pinched nerves. So in the spine, we have the spinal canal, we have the intervertebral discs or the shock absorbers between the vertebral bodies, and the nerves come out on each side of the neck and the spine and exit to go into the arms and the legs. If there is a buildup of arthritis, which is commonly referred to as bone spurs or osteophytes, or if there's a bulging disc, or if there's a thickened ligament in the spine, those together result in a pinched nerve or a radiculopathy. And typically what patients experience is pain in the arm or the leg that radiates in a specific distribution. And if it radiates down the back of the leg, down the back of the thigh, and into the foot, we call that sciatica, commonly caused by disc problems, variously described as searing, sharp, aching, or throbbing, and an excellent example of how a mechanical issue becomes a neuropathic pain condition, the mechanical issue being the bulged or herniated disc, resulting in a neuropathic pain problem in the back or leg. Peripheral neuropathies, this is a general term that means sick nerves, and it means sick nerves that occur kind of in the distribution of the distal nerves, or what doctors refer to as a stocking and glove distribution. And this may be burning, numbing, tingling, kind of in the hands and feet, commonly seen in the setting of diabetes or metabolic neuropathies, can also be related to environmental exposures or genetic factors. So peripheral neuropathies can result in chronic pain, chronic neuropathic pain. And finally, here's that condition I talked about earlier called complex regional pain syndrome. Complex regional pain syndrome, or CRPS, is a primary form of nerve damage that affects the nerves that regulate the automatic or the autonomic functions in our body: sweating, temperature, even sensation. It used to be disputed whether autonomic nerves could transmit pain signals, but it's not disputed anymore. They can transmit pain signals. And when this area of the nervous system, when this part of the nervous system goes awry or haywire, it results in almost a combination of a peripheral neuropathy and a radiculopathy: burning, searing, numbness, and numb, tingling pain, often associated with temperature irregularities or changes in skin color or thinning of the nails or hair loss in the distal hands or feet. Complex regional pain syndrome is a life-altering diagnosis. The good news is that it's a very treatable condition. And when simpler treatments fail, neuromodulation is a very good treatment for complex regional pain syndrome, and we'll talk about that in a few minutes. So some things to consider. Again, pain needs to be addressed holistically. So we sort of talk about tiers of treatment in medicine, and we talk about first-tier treatment, which are sort of simpler treatments like cognitive behavioral therapy, kind of learning what I describe to patient as Jedi mind tricks to deal with distracting yourself from pain. Because again, being focused on your pain is normal because pain hurts. So you're swimming upstream against very strong protective mechanisms to learn some techniques to distract yourself from pain. Non-steroidal anti-inflammatories, topical peripheral nerve stimulation devices, all can be very effective treatments at the first tier level for management of neuropathic pain. Then we get into second tier treatments. These are things like diagnostic and therapeutic nerve blocks, pain medications, and we'll talk a little bit more about that too. Again, when things in the first tier don't work, the second tier become an option. And then finally, we talk about third tier treatments, things like neuromodulation, spinal cord stimulation, radiofrequency ablation. And I would say that, we refer to it as a third tier treatment, but more and more, as we learn about the treatment of these conditions, we recognize that gaining access to some of these more advanced treatments is probably something that ought to be considered sooner than later, because we want to prevent the chronification of pain. And we'll talk a little bit more about that later in the talk. So a little bit of history and a little bit of context for the field of chronic pain management is, it's no news to most people that we are still dealing with an opioid epidemic. And in fact, in many ways, the extent of the opioid epidemic has become worsened as we've dealt with situations related to COVID-19. So we see that pain medications can be an effective short-term treatment for pain. There are people who do benefit from low-dose therapy of pain medication for chronic pain conditions, but it has to be very carefully monitored because we understand now the risks of overdose, addiction, organ damage, tolerance are much, much higher than what we estimated them to be 15 years ago. So opioid medication, and they have a role in chronic pain management, but they're certainly not as large a role as we once thought they would have. Other medications commonly used for particularly neuropathic pain are things like pregabalin or gabapentin. These are medications that affect the calcium channels on nerves. There are medications that are in different classes like antidepressants or anti-seizure medications. And again, you'll notice that all of these drug classes are affecting nerves, and that's because neuropathic pain is a nerve disorder. So just because your doctor prescribes you a antidepressant for the treatment of your neuropathic pain doesn't mean your doctor secretly thinks you're depressed. It recognizes that these overlapping pharmacological effects affect the perception and modulation of pain in the body. Finally, there are injection therapies. Injection therapies can be very useful in the diagnosis and treatment of pain. It can help a physician decide what part of the nervous system is mostly involved in a pain condition. Things like epidural steroid injections, medial branch blocks, facet denervation, sacroiliac joint injections, and radiofrequency ablation. These are common interventional pain procedures that can be used to treat both mechanical pain and sometimes can palliate or alleviate symptoms related to neuropathic pain. And again, the hallmark of good pain treatment is not relying on just a single modality, but combining these modalities and tailoring them to the unique situation of every patient. What about spine surgery? Again, there is no doubt that there are times when patients need to have surgery for a issue related to their spine, particularly if they're experiencing what's called progressive neurological deficits, things like ongoing weakness or bowel or bladder changes, or if there are mechanical issues that make the spine inherently unstable. These are good reasons to consult with a spine surgeon about having spine surgery. One of the worst reasons to see a spine surgeon, especially straight out of the gates, is for a pain problem. We know from the literature that if the indication for operating on a person's back is primarily pain, the outcomes are not as good compared to surgeries that are directed towards alleviating things like neurological deficits or correcting mechanical deficiencies that result in instability. So I would be very cautious about any physician who thinks they can cure your pain problem with surgery. There's just not good data to support that in most cases. Okay, let's jump into our first sort of deep dive topic, and that's neuromodulation. So when we talk about neuromodulation, we're talking about low dose electricity directed to the spine to affect the perception, to modulate the perception of pain in the body. And we can do that at least two ways. We sort of we look at pain that is kind of more focal in distribution, like a radiculopathy or a pinched nerve that I talked about for a sciatic type condition, or pain in a specific territory of the nerve of the hand or the foot. For those sort of pain problems, we can target a very specific area of the spine called the dorsal root ganglion and use low doses of electricity to modulate how that pain is being processed at that level of the spine, and not just cover up pain, but change the perception of pain in the brain. All pain is felt in the brain. It's referred to the hand, but it's felt in the brain. So for focal conditions, we talk about using spinal cord stimulation treatments like dorsal root ganglion. For broader conditions, for pain that kind of involves, you know, the whole area of the back of the hip or the whole arm and shoulder, um, those kind of pain distributions are covering multiple areas of the spine, and we want to use a broader approach. So we use what's been traditionally referred to as dorsal column stimulation, or traditional spinal cord stimulation, where we put a long lead across multiple areas of the spinal cord above the spinal cord. And one of the most exciting advances in the last few years, which are last 2 or 3 years, which I'll talk about, is really a deeper understanding of how specific waveforms can be tailored for the treatment of neuropathic pain. And this has led to some exciting new options for patients. So neurostimulation therapy is a non-opioid alternative for neuropathic pain. It's well established. The field keeps evolving, but the core ideas have been around and the core technology have been around for well over 30 years. We've really gotten a good handle on how to use this therapy appropriately for a wide variety of pain conditions. Sometimes it's kind of referred to as sort of a pacemaker for pain, because the two elements of any spinal cord stimulation system include a battery or a pulse generator and then a wire. So you have to take the electricity from the battery and get it to your neurological target, and you do that via a wire. So conceptually it looks a lot like a pacemaker for pain. One of the exciting things about this treatment is that, there are few things in medicine that you get to test drive. So you can't test drive a surgery, but you can test drive neuromodulation. All patients are required to undergo a trial of the therapy to see if it's a good fit. It doesn't matter how great a diagnostician your doctor is. If you don't get good benefit from a trial, you're unlikely to get good benefit from a definitive implant of the system. And we'll talk a little bit more about that process in a few slides. So again, just elaborating a little bit, a little more deeply on how neuromodulation works. Pain signals travel up the spinal cord to the brain. All pain is felt in the brain. A battery or a pulse generator is used to administer low doses of electricity to a neurological target. The pulses block the pain signal at the neurological target before they reach the brain, and the painful feeling is replaced with another feeling. And it's sometimes described as tingling or buzzing, but again, it's very patient specific. Sometimes it's just replaced with the absence of pain. So what are the goals for this treatment? Well, of course, obviously one goal is to alleviate your pain. And we consider the alleviation of pain to be a 50 to 80% reduction. And patients commonly, this is a good treatment for patients who report during their trial that they experience 50 to 80% improvement in their painful symptoms. We just don't want to see pain reduced. We want to see function improved as well. So again, the point of this therapy is to make people more functional. So we ask that during your trial, you monitor your ability to do things that you value as important to your quality of life. We would like to see the reduction of pain medication as possible, if possible, but we recognize that if people have been on pain medications for a long time, sometimes it's hard to reduce pain medication because it's something that's been helpful for a patient. They've, you know, come to become fearful of discontinuing medication. So we like to see people reduce their pain medication, but it's not a requirement. And again, I talked about the test drive part of this treatment where you are able to experience the therapy on a trial basis before committing to a permanent implant. So who is a good patient for neuromodulation? Well, if your pain is predominantly neuropathic, not mechanical, if it's been present for longer than 6 months, if it's persistent, if it's difficult for you to modulate, so you can't find a comfortable position or you can't find some way to distract yourself from the pain because it's constant and interfering with your quality of life, if other tiered therapies haven't helped, and if you've had a consult with a surgeon and they've recognized that there is no structural instability of the spine, there is no progressive neurologic deficit that surgery can correct, then you are a good candidate for neuromodulation. And again, we've gone through this list before, but these are some of the common conditions or diagnoses that um, are effective for neuromodulation: post-laminectomy pain syndrome, radiculopathy, causalgia, neuropathies. We've gone through this list before. So the evidence for this therapy is strong and continues to get stronger for both the focal spinal cord stimulator therapies like the DRG treatment and for the broader spinal cord stimulator therapies like the dorsal column long leads. So in both situations, we've had dozens of studies come out supporting the efficacy of this treatment, and that's another presentation unto itself, but a fascinating topic. This is a durable treatment, and that's really the take-home message I want you to get from this, that if you are properly selected and you have a successful trial, it's expected that this is a therapy that's going to help you for years and years. And this slide is pretty busy, but I really just want you to get the takeaway message here that this has been studied in well over 1,000 patients at this point, over more than a decade. And again, what we see is very consistent results, i.e. the reduction of pain and improvement of function. And it doesn't matter what sort of flavor of spinal cord stimulation is studied, the results all tend to point in the same direction, with some nuances based upon diagnoses, but the general consensus is emerging that this is a durable, long-term treatment for chronic neuropathic pain. Having said that, one of the more recent advances has been a recognition that not all waveforms are created equally. And what do I mean by that? When this therapy first came out, there was really just one option, and it was a very stereotypical kind of administration of electricity to the spinal cord. It definitely worked. It's been foundational to the evolution of this field. However, with advances in technology and the ability to understand the nervous system in a more kind of fine-tuned way, we've been able to develop waveforms that are more physiological, that actually talk to the nervous system, that aren't just trying to distract it or cover up a sensation, but are actually interacting with areas in the brain and the spinal cord in a way that actually reflect the physiological function of the target. That's really exciting. And what we find is that when we offer patients these more customized waveforms that are more kind of grounded in the actual neurophysiology of the nervous system, patients like it better. It sort of makes sense, right? So, for example, for dorsal root ganglion stimulation, that's spinal cord stimulation that's directed over a very specific area of the spinal cord for a focal pain issue. more than 80% of patients, 8 out of 10 people, report experiencing significant relief at 12 months. Now, the effects go on well beyond 12 months, but doctors have to stop a study at some point. But I can certainly say that at a year, patients have experienced very good relief, and in my clinical experience, that phenomenon is durable. It goes on for years afterwards. So at this point, I hopefully have stimulated some questions, no pun intended. I've stimulated some questions in your brain about spinal cord neuromodulation. So will neuromodulation cure my pain? Well, there is no cure for pain because pain is, again, as I led with, this kind of whole body experience. It's in the brain, it's in the spinal cord, it's in the mind. So neurostimulation does not cure pain, but it's an effective therapy that can reduce pain to a manageable level. And again, we also target function as part of that. And will it be able to reduce my medications? As I've said before, we like to see patients experience a reduction in their pain medications, as do most patients. Most patients do not want to rely on a pill for pain relief. And some patients are able to reduce the use of pain medications using spinal cord stimulation. So it's an issue that gets sort of addressed on a case-by-case basis. Are there restrictions to having an implanted stimulation system? So this is not talking about a trial, but actually talking about someone who's gone on to have a permanent implant. During the healing phase of the surgical implant, there will be some restrictions, mostly in lifting, bending, twisting. But then once things heal up, I've had patients be very active using this technology, often going on camping trips, hiking, participating in golfing, bowling, other outdoor activities. So once you're past that 6-week mark recovery from surgery, patients are able to be very active with this technology. And then finally, how accessible is this? So, of course, that varies a little bit, our ability to get in and get assessed for the treatment. But once the trial is completed, our center really focuses on getting patients access to that definitive implant procedure in a timely fashion. And typically our target is less than 4 weeks. Okay, that concludes sort of our first topic of neuromodulation. I want to shift gears a little bit and talk to you about another exciting treatment alternative for patients, and that's regenerative medicine. And I'm going to focus on a subset of regenerative medicine procedures called platelet-rich plasma and bone marrow aspirate concentrate therapy, or stem cell therapy. Our center, Columbia Pain Management, we have licensed and have an affiliation with a group of providers, a network of providers across the country called Regenexx. And basically what that means is that we all share some common understanding of treatment protocols, and we collect standardized outcome data on patients. So if you were to see one Regenexx doctor in California, and then you were to move to Oregon and need to see myself or one of my colleagues, the kind of therapy you would access would be the same in Oregon as you receive down in California. So it helps us standardize our treatment approach. So again, we've talked about that, we're sort of being very cognizant about relying on opiates for long-term pain management. So we want to provide patients as many options as possible. Things like neuromodulation and regenerative therapy are among them. The barrier we face, and it's less of a barrier for neuromodulation because insurance does widely recognize neuromodulation. But for regenerative medicine, some insurance companies are still not fully covering this. So it's too bad, because we'll see the data for regenerative therapy is actually quite good. It can still be a little bit of an uphill battle to access that treatment for patients, unlike neuromodulation, which is more widely available. So often what doctors have relied on instead of regenerative medicine is we've relied on things that insurance companies will pay for, and they pay for steroids. And steroids for the treatment of mechanical pain or musculoskeletal pain is recognized, again, as a good short-term treatment. It has anti-inflammatory effects. It can really put out the fire and allow a patient to begin rehabilitation and physical therapy But we do understand that there are long-term consequences to prolonged steroid exposure. So for example, scientists have found that in our joints that are lined with cartilage, exposure to steroids, high-dose steroids, can actually cause cellular death among the cells that create cartilage. So oftentimes patients are seeking treatment for arthritis, which is a cartilage condition. They get a steroid shot. They may get some temporary short-term relief, but it's just not durable. It's not a durable treatment. They go back in, they keep getting steroid injections. Over the long term, that actually ends up being quite unhealthy to cartilage cells. And it's even been shown that one dose of steroid injection can facilitate a cascade of degeneration in cartilage and actually worsen the progression of arthritis in some cases for some people. So steroids can be chondrotoxic or toxic to cartilage. They also affect other parts of the body too. So we see changes in skin, muscle, bone density. And again, you know, when you're trying to heal from an injury, the last thing you want to do is reduce the body's ability to heal. So have to be careful with the side effects and the overexposure to steroids. So what can we use instead? Well, one novel application has been concentrating platelets. So taking platelets from a patient, their own platelets, and concentrating them down. So why platelets? Well, we've all had the experience of getting a cut and having you know, a small bleed, and then eventually the bleeding stops and the cut heals. It's platelets that start that process. It's platelets that begin to clot the blood and begin to release chemical messengers that attract stem cells into the area to facilitate tissue repair. So platelets are a key are a key driver of tissue regeneration. Platelets contain growth factors, and so by concentrating platelets, we concentrate the growth factor. That's platelet-rich plasma. And then by activating the platelets, we send a very strong chemical signal to a tendon or a joint that this is an area that the body needs to focus on to facilitate tissue repair and tissue healing. So that is platelet-rich plasma. So what you see on the screen is an example of a platelet-rich plasma product. It's been put in a high-speed centrifuge and fractionated. And what you see on the bottom of the red are the blood products, and what you see at the top is the plasma. And in between, you see a layer that's kind of a little cloudy. That's the layer that contains the platelet-rich plasma that we're able to isolate. And again, this can be done two ways. It can be done using a centrifuge, or it can be done using what I think of as a platelet barista. And in our practice and in all Regenxbio practices, we use a manual tissue processor to help us customize our tissue, our platelet-rich plasma formulation to specific tissue, specific patients' needs. Just like neuromodulation is a therapy that's customized to patients, regenerative medicine is also a therapy that's customized to patients. So there are a lot of different kinds of platelet-rich plasma on the market, and what this slide illustrates is that if you go in for a platelet-rich plasma injection and the doctor waves something in front of you that looks red, that's not platelet-rich plasma. It may have concentrated platelets in it, but real platelet-rich plasma is kind of amber or yellow in color. So there have been concerns about patients receiving what are called regenerative treatments and then not getting good benefits and then thinking that this is just not a treatment that's going to work. Well, it might be that they didn't get the optimal kind of treatment for their problem. I want to go through this study a little bit and just show you for the treatment of knee osteoarthritis, this study compared an injection of platelet-rich plasma, a tissue lubricant, a joint lubricant called hyaluronic acid, and steroids. So it was a randomized controlled study. Patients got randomly assigned. They all had knee osteoarthritis. They all got assigned to either a PRP group, a joint lubricant group, or a steroid group. And then they were followed up. Well, look at this data. This is very interesting. So what we see is that pre-treatment on the left side of the screen, the patients were very similar. They had very similar scores, very similar concerns and complaints about the pain and function in their knee. At 3 months, they all had similar benefit. But look at what happens at months 6, 9, and 12. We see that the joint lubricant group and the steroid group tend to drift back up to being worse. So in this slide, worse is towards the top, and the PRP group continues to improve. That's very compelling data. And what that suggests to me is that regenerative medicine is a durable treatment because it's actually healing tissue in a targeted location of the body. So just like neuromodulation being a durable treatment for neuropathic pain, regenerative medicine can be a durable treatment for cartilage and bone disorders, cartilage and joint disorders. A little bit about stem cell therapy. There's been a lot of this in the news, so I just want to spend a couple minutes talking about stem cell therapy. So when we say stem cell therapy, that can mean a lot of different things. It can mean embryonic stem cells, which come from an embryo, and these are cells that can sort of grow up and be anything that they want. There are ethical concerns about using embryonic tissues, right? I mean, I think we all have a sense of that. Then there are adult stem cells that can be harvested from a patient and injected into different parts of the body. Mostly these tissues come from bone marrow or from adipose tissue. And then there are stem cells that can be grown in the lab. So they're kind of synthetic stem cells, which is an emerging area of research, but still a little new. In our practice and in any Regenexx practice, we use bone marrow and sometimes fat that are adipose tissue that come directly from the patient. And that's because, particularly with bone marrow stem cells, these are cells that have sort of picked their major in college already. They know they want to be a cartilage cell or a bone cell or a tendon cell or a ligament cell. They've pretty much excluded that they want to be a heart, pancreas, or lung cell. So they're a little more along the lines of differentiation. So that makes them to use regenerative medicine for musculoskeletal or mechanical pain. And the cells act two ways. They certainly have a regenerative effect. They are going to regrow tissue, but they're also going to change the chemical environment of where they're put. So sometimes these cells, these mesenchymal stem cells or stromal cells, have been kind of renamed medicinal signaling cells because while they are regenerating tissue, they're also sort of changing the nutrients and changing the soil, if you will, in the area that they're placed to help facilitate tissue regeneration and healing. This is an example of how we do a bone marrow aspiration. We do it under X-ray guidance. People often have a lot of concerns that this is a painful process. It really isn't. With using local anesthetic, patients report that this is actually the least painful part of their regenerative medicine procedure. So under X-ray guidance, we take a needle and we insert it into the back of the hip, kind of where your back pocket is, in the area of your back pocket, and we aspirate bone marrow. And we take that bone marrow and we concentrate it, we get the stem cells out of it, and we re-inject it into damaged areas of the body. So this is a great study. This was a very elegant study that looked at using bone marrow aspirate concentrate in patients with knee arthritis, at least moderately to severe, at least moderate and up to severe, so grade 3 and grade 4. So this is the effects of one bone marrow aspiration concentrate injection, one stem cell injection. These were patients who were basically being told, you need to go get a knee replacement. There's nothing I can do for you except replace your knee. Let's see what happens when they get a bone marrow stem cell injection instead. So this is the data from the study. So we see pre-treatment that the blue is their pain. So they're reporting an average of 8 out of 10 pain, which is pretty severe if you think about what an 8 out of 10 pain means to you. And their function is quite low. So on this 50-point scale, their function is about 20, okay? They have one bone marrow stem cell injection, And what happened 6 months later? 6 months later, they're reporting significantly reduced pain. It didn't go to 0, but it went from 8.5 to a 5. That's pretty good. Most doctors consider a 4 or 5 to be tolerable pain. But look what happened to their function. Their function went up 13 points. So again, these are patients with severe osteoarthritis, told that they've had no other options except a knee surgery, and they've instead gotten statistically significant reductions in their pain and statistically significant improvement in their function. So quite an impressive result for treatment of a mechanical pain disorder in patients told that there's no other option except surgery. Okay, I want to leave you with some final thoughts, and then we'll discuss, we'll open things up a little bit for questions. So pain management is undergoing a huge evolution, and we're seeing technological advances that give patients more options. Neuromodulation spinal cord stimulation is a proven non-opioid, non-medication treatment for neuropathic pain resulting from nerve damage, either from primary nerve damage or secondary nerve damage related to treatment of another condition. It's durable, it's minimally invasive, and it's got backed by 30 years of science to support its efficacy. Regenerative therapies, new, offers promising results for mechanical and osteoarthritic conditions. Both treatments can work synergistically with other treatments that patients may be accessing, and both treatments are accessible to you locally. So if you're interested in learning more about these treatments and whether or not either or any of them are appropriate for you, or if you just want to sit down and meet with a pain specialist and get a total assessment of what your underlying pain issues are and what treatments are available, then I would invite you to visit us on the web at www.columbiapain.org. If you go